Good evening and welcome everyone to the US2 Prostate Cancer Connections webinar on imaging. My name is Terry Lakowski and I'm the program director for US2 and I'll be your host tonight. I'm really excited to share that we have over 450 registered for the event and many of you are listening from all over the US and several other countries including Australia, the UK, Finland, Tunisia, Aruba, West Africa, Belgium, and Canada. That's really cool. US2 is here to empower men diagnosed with prostate cancer and their loved ones with the educational resources and support services to help fight prostate cancer. Our website offers a wealth of information at no cost to help make informed decisions on prostate cancer testing, active surveillance, treatment options, and management of side effects. Through our support groups, and now due to COVID, several additional virtual groups, online support services, newsletters, educational materials, and events like tonight, US2 will help transform resignation into determination and fear into hope. Part of US2's mission is to help ensure that support group leaders and prostate cancer patients have access to the latest information about new pharmaceutical products and therapies related to prostate cancer. While we do not endorse any particular drugs or therapies related to prostate cancer, we do want you to be aware of what's currently available so that you can make the best possible decisions in conjunction with your physicians. So we've gotten so many questions from all of you already, but we do have a chat box where you can continue to send more. So our presenters will continue to try to answer as many possible questions throughout the night. So if you guys want to send in your questions at the chat there on the right, feel free to do so. But please understand that it's going to be really hard not to answer all the questions. We'll try our best, but it won't be possible to do that, but we'll do our best. So we have a lot to cover, so let's get started, and we're going to introduce all the speakers for tonight. Our first speaker will be Dr. Brian T. Helfand. Brian is the Richard Melman and Ron Shea Family Chair and Chief of Urology at NorthShore University HealthSystem in Evanston, Illinois. He's an associate professor at the University of Chicago and former adjunct professor at Northwestern University. He holds MD and PhD degrees and is head of clinical and research programs focused on prostate cancer. Dr. Helfand has authored more than 200 peer-reviewed manuscripts. Currently, his interests are devoted towards using novel imaging techniques and biomarkers. He also talks a lot about genetics to help guide clinical decision-making for men with newly diagnosed and advanced prostate cancer. We also have tonight joining us Dr. John F. Feller, who is the Chief Medical Officer at HealthSystem. Dr. Feller has co-authored numerous peer-reviewed journal articles, book chapters, is an editor of the textbook Shoulder Magnetic Resonance Imaging. He has given over 400 invited lectures worldwide on orthopedic prostate and body MR imaging. Dr. Feller's current position is the Chief Medical Officer for HealthSystem. Most recently, Dr. Feller started and leads an MRI-based prostate cancer detection and focal therapy program at HealthSystem that has provided care to over 3,000 men, and he serves on the founding board of directors of the Focal Therapy Society. Next, we have Ms. Bernadette Greenwood joining us tonight. Bernadette is the Chief Research Officer at HealthSystem. Ms. Greenwood earned her postgraduate certificate in imaging at the University of Edinburgh. She has worked in government, industry, clinical, and research settings with 30 years experience in medical imaging, marketing, clinical education, regulatory affairs, product management, and R&D. She conceptualized and developed focal laser interstitial thermal therapy of prostate cancer with a transrectal approach under MRI guidance in 2009, patent pending. In her current capacity as Chief Research Officer at HealthSystem, she oversees clinical and research activities. She lectures frequently on topics related to oncologic oncologic imaging and is an internationally recognized expert in prostate MRI and MR-guided intervention. And lastly, joining us tonight, we have Dr. Jeffrey Herz. Dr. Herz is a board-certified urologist with HaloDX. Dr. Herz currently practices at HaloDX, focusing on the prostate cancer program. His specialty covers both adult and pediatric urology. However, most recently, he focuses much of his attention on adult urology services, primarily prostate cancer. He was born and raised in New York City, New York. He opened his practice in 1980 in Rancho Mirage, California, and has been a practicing urologist for the adult and pediatric community for over 40 years. His expertise has gained him honors as one of the top doctors from 2005 to 2018 in the Palm Springs Life magazine. So we're going to start off tonight with Dr. Brian Helfand. Dr. Helfand, welcome.
Thank you. Just calling this up here. Okay, let's just get one more thing. All right, so thank you guys, and certainly depending on where you are in the country, hope you are having a great night. And again, as we continue on this unique era in COVID, thank you all for attending, virtually, and one day certainly always look forward to meeting as many of you in person as I can. I do strongly support US Too. It is a foundation that's near and dear to my heart as a urologist and urologic surgeon who treats men solely with prostate cancer and focuses my research program on that. So as mentioned, I'm actually based in the Chicagoland area. I'm located in Evanston at NorthShore University, which is an affiliate of the University of Chicago. Again, my clinical and research interests really are in using biomarkers, including genetics, genomics, and certainly imaging to further advance prostate cancer decision-making from the time of screening to certainly advance prostate cancer. My disclosures in this talk is that I am a speaker, advisor, and investigator for Blue Earth Diagnostics and have a large interest in using imaging to personalize treatment strategies. Today, I'd really like to talk about the Axumin flucyclovine F18 scan. And that's a really kind of a big mouthful, but it really should not be intimidating. And really understanding how it is a PET CT imaging modality. A lot of people refer to it as a next generation imaging modality that can be used to better understand the role in the management and treatment of recurrent prostate cancer. I'd also like to tell you about how different imaging options can help the urologist, but your treatment team to diagnose and locating recurrent disease, as well as what are the different imaging modalities out there, and specifically understand the process of obtaining a PET CT scan, such as Axumin, for answering this question. So the interesting thing is when it comes to recurrent prostate cancer, you're not alone. And this is really kind of unique because most people believe that, hey, I was diagnosed with prostate cancer, I was treated, and therefore I'm cured. And the problem is that a cure really, you're not given the diagnosis of a cure for really up to over 20 years following your initial treatment. Instead, you're kind of what most people would call in remission or no evidence of disease for that time period. And we're often following you and your PSA values after treatment to make sure it's not coming back. But when you look at the incidence of recurrence, in the first 10 years after the initial treatment of prostate cancer, up to 40% of patients will have or experience a recurrence. And that number is even higher if you follow men up to 20 years, where up to 50% of men will actually experience a disease recurrence. And what does recurrence actually mean? It means that the prostate cancer has returned. People say, well, how is that possible? I was treated. Again, cells have escaped or never were treated at the time of your definitive therapy. And as such, those cells ultimately, because prostate cancer is generally very slow growing, can over a 10 to 20 year period start to regrow or form. And as such, it is still prostate cancer, but it is recurrent after your definitive treatment. And this recurrence can really occur after any form of treatment. Okay, this includes prostate surgery, hormone therapy, radiation, chemotherapy. Anytime you have a change in PSA that's increasing, it generally means in some ways that your prostate cancer is coming back. And again, prostate cancer recurrence is not really just limited to the prostate. Again, as a surgeon, people say, well, my prostate's out. Is that still prostate cancer? It is, and it has recurred, and generally thought because either cells spilled over at the time of surgery or they crawled out before surgery even happened. And that recurrence can occur almost anywhere in the body, but generally can occur where the prostate used to be, or in the prostate. If your prostate was taken out, it can occur in the prostate bed. Or if you had radiation, it can occur in the prostate. It can occur locally in the pelvis, in pelvic lymph nodes or other soft tissue, or it can actually metastasize to distant spots, such as those in the bone and other locations. And again, so when you have prostate cancer recurrence, it doesn't mean that it's always located where the prostate used to be. It can be in other locations as well. But you can imagine that it's really important that if you are going to treat a prostate tumor recurrence, it's important to understand where that tumor actually is located. Because again, we don't want to treat a part of your body and then second guess and say, well, it was actually located in another spot. So our treatment failed and you received unnecessary therapy to another part of your body that the prostate cancer didn't exist. So it's important to talk to your healthcare team and make joint decisions to help better understand where your prostate cancer recurrence is. Again, this is so important because it's one of those where I always discuss with patients that it's very important for patients as well as their family members to be your own advocate. Yes, we are looking out for you and looking out for your best interest, but it is a joint decision-making process that should occur, a truly shared decision-making. And it's important, therefore, that you know about these type of imaging techniques so that you are getting the kind of latest and greatest opportunity so that if you do have a recurrence, that we can locate it appropriately. And so how, again, do we define recurrence? And this, again, comes to the meaning of elevated PSA levels. So again, there's a lot of controversy in the setting of what does a PSA value mean before definitive treatment. But after you receive surgery, it should go to 0 or undetectable. Or after you just receive radiation, your PSA value should go to a low level and ultimately stay at that low level. And if PSA starts rising, then your cancer could have recurred. And again, when you look at a typical scenario of patients who experience recurrence, is that patients often have an elevated PSA that ultimately leads to a diagnosis, a biopsy, or some other form and diagnosis of prostate cancer. They're offered definitive therapy, and then their PSA should decrease. And again, it should stay there, but in some patients, up to 40 to 50% of them, that PSA value will then start rising over time, indicating that the prostate tumor has recurred. And again, I'm talking about surgery or radiation, but this could be hormones. You were treated because you have metastatic prostate cancer, they gave you hormones, your PSA fell to a low level, and that at some point it started to rise. That's where we start wondering if and where the prostate tumors are located. And again, learning where the prostate cancer is located can really help the healthcare team, including you, choose the most appropriate treatment plan. Because again, we have recognized that if we adjust those plans, we can make a more accurate treatment for you when we know where the prostate tumor is located. So how do we locate recurrent prostate cancer in any individual patient? we typically use imaging tests, which can provide us with more information about recurrent prostate cancer. And again, knowing where that recurrent prostate cancer is can really lead to more personalized treatment. And again, this is one of my research focus. And the thing that I'm really most passionate about is let's not overtreat or undertreat patients. Let's come up with a treatment plan that is right for that individual based on that where that prostate tumor is located. And again, historically, and even more recently, we've really used bone scans and CT scans and MRIs to locate these recurrences. And again, for those of you who know or what a bone scan is, it is looking for really disease, the presence of prostate tumors within bone. And again, prostate cancer has a predilection to spread to bones. And the way that a bone scan would work is that you would get a radio tracer that would highlight some modality in the bone if there was a recurrence there. But the problem is, again, this has been a technology that has been around for many, many years, but is really only useful at relatively high PSA levels. Your PSA level should be greater than 10 and arguably greater than 20 before that bone scan is actually positive. And when you look at the rates, once your PSA gets to 10 or 20, you would say, well, everyone who has a recurrence should have a positive bone scan. But really, it's only 20% or less of men that will, even at that level, have a positive scan. And when you look at CAT scans, which is another common imaging modality, it's not as good at locating disease recurrence in the bones, although it can, but it's also, it's good for soft tissue detection, such as those within lymph nodes, et cetera. But it's really not good if you have a small tumor. Again, when you look at the resolution on a CAT scan, and that's historically what we've done, is it can miss many smaller tumors or lesions. And MRI, again, has been used in a lot of biopsies, and I think tonight you'll hear a lot more about MRI imaging modalities. But in and itself, it also, while somewhat controversial and isn't routinely used to locate recurrence, is more frequently used, but it can still miss things, and it can miss small things. And again, you need a much higher PSA level to really routinely detect small lesions. And again, if you have any metal inside your body, a pacemaker, et cetera, you cannot get that. So again, these are kind of the conventional imaging that we historically have used, the bone scan, the CT, and even now the MRI, but they're not perfect. And you have to wait until your PSA levels are often high to detect something, and it still will miss things. And if we wait until your PSA levels are that high, you may have missed a treatment window or opportunity. And again, so are there newer tests that can help localize these type of cancers with more reliability at lower PSA levels? And that's really where we get into the next generation imaging, or NGI, if you want to sound really cool, where we can locate these recurrent prostate tumors. So what is an Axumin flucyclovine PET CT scan? That is really the answer to a lot of these problems in locating prostate tumors. So the Axumin flucyclovine scan is a diagnostic imaging agent, again, sometimes called a radio tracer. And that's just a fancy way to say that you're injected with a small molecule, a small medicine, if you will, that is selectively uptaken by prostate tumor cells in the body. And again, this is something that is indicated for those men who have failed either therapies with either radiation, surgery, or hormone therapy, or other modalities, and their PSA is on the rise. And we can actually give this radio tracer to that to be uptaken by prostate tumor cells, and then we can scan you through a PET scan and a CT scan to detect where in the body these are located. And again, with any type of imaging modality, it's important to understand, are there any kind of risks associated to the patient with this? And the truth is, this has been well studied and documented, and that Axumin scans are very safe. They do give a little bit of radiation, so people would say that the radiation equivalent is that of a CAT scan. It's important to understand that it's still not a perfect scan, and certainly compared to a bone scan or CAT scan or MRI, the sensitivity is a lot better. But just because you have a positive or negative result doesn't mean that the results are perfect, meaning that if you have a negative result, it doesn't mean that you don't have a recurrent prostate tumor. And if you have a positive result, it doesn't always mean that it's in that area. And again, the higher your PSA levels go, the more likely it is that the Axumin would be positive. Of course, even at values of under 10, it works very well, and it goes down to very low. And I'll show that data shortly. Severe serious reactions during Axumin, like any type of imaging which involves any type of contrast or radio tracer, are possible. They're extremely rare, and to my knowledge actually have never been reported, but it's important that we know about them, such as you may have difficulty breathing or anaphylaxis. That's the same as if you took an aspirin kind of thing. It's just very rare, but we always have to warn about it. And again, it does involve CAT scans, which it does have some radiation, but it's generally very safe and doesn't really, that we know of, increase greatly your risk of any other problems. What are the possible side effects to Axumin? Again, it's very safe, but well studied and well tolerated. The most common things are mild to moderate injection site pain, mild to moderate injection site redness, an unusual taste in the mouth that we call dysgeusia, which is really a metallic taste, again, very rare. And again, if any of those you have it, you should inform your doctor. Most of the time, if you do experience it, it goes right away, but we do take note of it. Any other types of side effects, you can always call and ask for additional information, or if you have something unusual, report it to the FDA. The Axumin scan, again, is an advanced diagnostic imaging or next generation imaging agent used along with the PET scan for men who have had prior treatment for prostate cancer and now have elevated or rising PSA levels. So how well does this work? And again, remember, if I'm talking about a CAT scan or a bone scan, we really have to wait till PSA levels are greater than 10 or certainly greater than 20 before we see a proportion of those that would be positive. When we're talking about the Axumin scan, it actually does perform very well at much lower levels. And again, there have been other studies in addition to this, but this is one of the first studies that was published. And again, if you look at the purple bars here, that the rates of a positive scan increase as a function of your PSA levels. But even at low levels, this is certainly less than 1, and these frequencies of positive scans are going to be similar even if you lower the bar to less than 0.5. Or between 0.2 to 0.5, but it's between 30 to 40% of these scans would be positive. And again, when you're counseling patients, you say, well, yes, your PSA is very low, you have a very low tumor burden as a recurrence that I can detect, but is it worth getting that scan? Most patients, when you engage them in the conversation, say, hey, if you're telling me that there's a 30 to 40% chance that we may detect something while it's such a small tumor volume, go ahead, get that scan, because it will influence our treatment planning. And again, if you look at the areas where it's positive, most of those recurrences are going to be outside of the prostate area. And the yellow really shows that areas within where the prostate used to be or in the prostate, it's a lower percentage. But again, all of these increase as a function of your PSA levels. And even at a level greater than 6, or a value of PSA of 6, over 80% of those are going to be positive, which is still far better than any of the conventional imaging techniques. So what to expect when we get an Axumin scan? Again, what happens is the patient comes in. There's usually a certified center that you would send the patient to. You inject the radio tracer 3 to 5 minutes before the scan. The scan itself, you just lay comfortably on a table. It's not painful. It's not like an MRI where you're in a close, confined space. That takes about 20 to 30 minutes, and then the radiologist will review those images, interpret them, and then you discuss these image findings with your caregiver team. Again, based on that, you can plan and personalize your treatment for your recurrent prostate cancer. So again, what else can you expect from the Axumin flucyclovine injection scan, and do you have to do anything to prepare for this? The truth is you don't really have to do very much, but we do advise that you should avoid significant exercise 24 hours before the Axumin scan. I certainly have a lot of very active patients, and we like to keep them that way, but sometimes they will kind of overdo it. They will go for a long bicycle ride or a hard run. That muscle can tear, and there can be some subtle background uptake in muscles. Again, that wouldn't necessarily be confused for a recurrence, but it does make the image quality clearer. So we say no heavy exercise beforehand. With any type of imaging agent, just in case there is any type of malreaction, we say don't eat or drink anything for 4 hours before the scan. It is advisable, again, with any type of scan. So again, when you undergo the scan, it's painless. It lasts about 20 to 30 minutes. You just have to lie still as you possibly can, but you breathe normally. Again, it's not like an MRI where you have a clicking sound or the patients become claustrophobic. If you have any discomfort, you tell the staff immediately, and certainly they will address any needs. You do move slowly through that PET-CT scanner. So is Axumin covered by insurance? It is covered by the original Medicare and most private insurance companies. Certainly through the years, the coverage has significantly increased. I really don't have a problem obtaining this on almost any patient, certainly as long as patients meet the definition of recurrence. Sometimes different insurance companies will argue based on what that definition is. Nonetheless, I really these days don't have my patients do not have problems with coverage. And again, if there is any issue, the Blue Earth Diagnostics can help, kind of bypass a lot of those issues. Again, if you have any questions regarding reimbursement, there is a number to always call to help with this assistance in getting coverage for it. So again, if I'm going to give you a takeaway point here is whether we're talking about recurrent prostate, standard prostate, or kind of newly diagnosed prostate cancer, it's very important that you establish a true partnership with your healthcare team, and that unfortunately or fortunately includes you being your own advocate and asking questions. We love questions, and it really does enhance the experience and does help your treatment planning. So it's important for you to know about these scans and to utilize them in helping to plan out your treatment plan for prostate cancer recurrences. Again, it is important to find out where in the body the prostate cancer has returned. This will, again, personalize your treatment plan for those recurrences. And again, Axumin may help your team find those answers, even when other imaging modalities like bone scans have been negative. So even if you've had a CAT scan or a bone scan or an MRI in the past, it does not preclude you from getting an Axumin scan. And again, combining these results from Axumin and other tests, you can really create a personalized management treatment plan for your recurrent disease. And again, if you have any questions, you can always visit the website or contact the helpline to help answer those questions. And so with that, and to keep the program running, I'm more than happy to answer any questions you may have, but certainly always a pleasure to talk to this group.
So thank you so much, Dr. Helfand. So we do have time for a couple questions. So I'm going to start off. We've got one question. They're asking, how does MRI compare to a PET-CT scan for identifying recurrent prostate cancer?
So again, they very rarely have gone head to head. The MRI is not as sensitive and generally needs kind of higher PSA values. Certainly there have been studies that suggest that MRI is more sensitive than a CT scan for identifying some of those, but it doesn't have the sensitivity and necessarily can locate where the tumor is. Certainly there are studies that have now started to combine some PET scan or imaging with MRI imaging to see if we can get the best of all worlds. But again, that's in the research setting at this point.
Thank you. And then let's go for another question here. Is there a role for a PET-CT imaging in staging of newly diagnosed prostate cancer? Meaning, does it more accurately identify prostate cancer outside of the prostate?
Yeah, so this is a great question. And ultimately, I think, there, again, in the research front, a lot of interest is being put into this space because, again, when we are newly diagnosing prostate cancers and certainly patients who have, higher risk or even, high intermediate risk type prostate tumors, we often say, well, is your prostate cancer outside of your prostate? And if so, would local treatment with radiation or surgery really help you? Or should we start planning for more systemic type therapies? And again, in that role or setting, using a conventional CT or bone scan, most of those patients, unless your PSA levels are really high, really will have negative staging workups. So there is a lot of interest in incorporation of this PET imaging into the initial staging workup. Certainly the Axumin scan is not FDA approved for this purpose at this time, but I will say that there is a lot of research interest into this because, again, it is so much more sensitive and accurate that if we're going to stage you appropriately, meaning to figure out if your tumor is located truly only in your prostate at the time of diagnosis or spread outside your body, that we may ultimately incorporate the Axumin scan.
Thanks. And we've got time for one more question. So let's see. Can you comment on how Axumin scan compares to PSMA PET CT scan?
Another great question, and certainly something that is of hot interest in topics. Again, PSMA is another radio tracer that has been incorporated or used with PET CT imaging. So instead of doing a flucyclovine based radio tracer, which is what the Axumin is, that ultimately you can use a PSMA type molecule, so a different molecule in part of that. There really is no direct head-to-head study in this, in the sense that there was a study out of UCLA, which suggested that they may be picking up different types and areas of recurrence. Ultimately, an active area of investigation. We don't know their comparative sensitivity or how they really will pick up different things. I do know that Blue Earth Diagnostics is actively looking into PSMA imaging and how it compares. But again, coming to a theater near you, so to say, so we will see how those results come in. But again, it is important to understand the differences between different next generation imaging techniques, as well as how they will ultimately have the similarities and differences in locating that recurrent prostate cancer.
Thanks. Thank you so much, Dr. Helfand. It's always such a pleasure working with you. So Dr. Helfand's going to stick around for a little bit. If you all want to send any more questions in the Q&A, he'll try to get to a few of those if possible. So next up, we're really excited to welcome the HaloDX team. Welcome, HaloDX. Let's get everyone ready to get set up. And we'd like to start off with Dr. Herz. Welcome, Dr. Herz.
Thank you very much, Terry. As a board-certified practicing urologist for the past 40 years, I have experienced a lot of tremendous improvement in the way we diagnose and treat prostate cancer patients in that period of time. I've treated myself thousands of patients with prostate cancer, diagnosed thousands, treated them with radical prostate surgery that I did myself, referred thousands more for radiation therapy, and treated many thousands of patients who had definitive treatment and nonetheless had prostate cancer recurrences, as well as metastatic disease. So I've had a very broad experience over the years in treating patients with prostate cancer. And I think that, to fully understand and appreciate where we are today and where we may be going tomorrow, it's very instructive to look back and see where we've come. So when I opened my door to my practice in 1980, patients with prostate cancer diagnosis walking through that door were really mostly walking on their way to the grave. There was really nothing we could really do for those patients other than supportive treatment, maybe castration. We didn't have chemical castration in those days, so it was surgical. And of course, that was not a curative maneuver. It was more for palliation. And eventually they would succumb to prostate cancer death. In that period of time, since then, we have seen a lot of improvement in the way we treat patients. Initially, when we saw patients, we didn't really have CAT scans, no MRIs, of course, no PSA testing, which is why when we diagnosed prostate cancer in those days, it was a sort of a stumble type of a thing. We stumbled onto it by accident, and by the time we found it, it had already spread. So the real game changers here occurred in the late 80s and early 90s with the development of PSA testing, prostate-specific antigen testing, and almost simultaneous development of transrectal ultrasound-guided prostate biopsies, the so-called TRUS biopsy, which urologists could now do easily in their office. Previously, we did biopsies in the operating room under general anesthesia using large needles that were really developed to biopsy other organs, not the prostate. And we usually did it as a confirmatory diagnosis for what we felt was prostate cancer. It was not done initially to find prostate cancer early for treatment, but to confirm what we already suspicioned, that prostate cancer had spread. So these two treatments, these two modalities, PSA testing and TRUS prostate biopsies, really revolutionized the way we could approach prostate cancer treatment and diagnosis. And by finding prostate cancer early, before the cancer had a chance to spread outside the prostate, and by diagnosing it with in-office prostate biopsies very simply, we were now able to try to eradicate prostate cancer by attempting curative maneuvers such as radical prostate surgery or a whole gland radiation therapy. This was a tremendous game changer where survival rates significantly improved to 30, 40, and now close to 50%, as well as quality of life issues with the development of other adjunct modalities such as the Da Vinci robotic method of radical prostate surgery, which can reduce significant erectile dysfunction and also attempt to reduce urinary incontinence rates, and brachytherapy in an attempt to insert radioactive seeds that were higher dose radiation, but only focally administered to the prostate itself with less fallout to other surrounding organs, such as the rectum or the bladder. So I'll give you an example of a patient that I had years ago after PSA testing was developed, who was 52 years old and had Gleason's 9 prostate cancer, a rather aggressive prostate cancer. And in those days, he underwent radical prostate surgery as his best treatment option, there having been no evidence of any spread of the disease. But several years later, his PSA test started rising again, and it was assumed that his cancer had recurred in the bed of the prostate that had been removed, and so he underwent radiation therapy, and his PSA test went back down again. And several years later, his PSA test went back up and was found to have a small focus of metastatic disease in his pelvis. He was then treated with hormonal manipulative therapy, androgen deprivation therapy, and that was done chemically this time, not surgically. And he did well for another few years. And then he had recurrence again, and the PSA went up, and uh-oh, what else did we have available for this fellow? Oh, we look on the shelf, and here's a new treatment, Provenge, an immunovaccine for treating prostate cancer that's customized to the patient. Oh, that's a big advance. And he did well for a few more years. And then several years later, his PSA test went back up again. What else could we do? Oh, well, here's another treatment, another chemotherapy that is well tolerated that we could use, or a combination therapy that we could use, chemotherapy, immunotherapy, hormonal therapy. Well, to make a long story short, although maybe I've already was not able to do that, but this patient is still alive at 70, almost 79 years of age now. He outlived his wife. He raised 2 children during this period of time. He worked for his family routinely. He lived a normal life. And he continues to live. I get a Christmas card from him every year. So he's the poster child for prostate cancer treatment in the last 30 years. It's an exploding field. It's a very exciting field to be in today because of all the amazing advances that we can look at and participate in that benefit all our patients. And we're very pleased to be able to do that. So looking at that and at the this little short brief history that I've given you, you can see how far we have come in a relatively short period of time, in 30 years. And we have a lot more to do, of course, but it's very encouraging in terms of seeing where we're going with prostate cancer diagnosis and treatment. And today, of course, with the advent of new technologies like magnetic resonance imaging, MRI, diagnosis of prostate cancer, we're able to more accurately target prostate cancer. It's better, much better than the trust biopsies that we've done in the office with ultrasound guidance, which is really more of a regional biopsy. It's not a very targeted biopsy. And even fusion biopsies utilizing MRI guidance overlying the ultrasound imaging is still a little fuzzy, but direct MRI biopsy through the MRI bore is highly accurate. Not only can it detect prostate cancer in the MRI lesions that we see, but it can go to the most active part of those lesions to find the real prostate cancer that this patient is going to be treated for. So it's a very exciting kind of a thing to do. It also limits the number of biopsies that we have to take. Instead of taking the usual 12 or 14 biopsy cores with the trust biopsy, we may only need to do 3 or 4 biopsy cores from the targeted lesions on the MRI. So this is all, again, extremely exciting and very beneficial for patients in terms of diagnosing and treating prostate cancer. And things continue, including genomic stratification of patients who have prostate cancer to be able to prognostically determine how they are going to do in the future as far as recurrences are concerned, when the best time might be to consider retreatment if they need it, or additional treatment of prostate cancer. Again, these are things that are being done today and are continuing to be developed. Thank you very much for your attention, Terry, and the audience. I appreciate it.
Thanks, Dr. Herz. My name is Dr. John Feller. I'm the Chief Medical Officer with Halo Diagnostics. I've been a radiologist for 30 years and have invested the last 10 years of my career into investigating biomarkers, including advanced imaging, and their emerging role for the early diagnosis of clinically significant prostate cancer, and taking that to the next step with regard to image-guided therapy potential as well. So Dr. Herz's historic perspective is a great segue into the topics that I'm going to cover. I'm going to address some of the epidemiology and where we're at with screening for prostate cancer in 2020. And then Ms. Greenwood will jump on and cover multi-parametric MRI and the role of MR targeted biopsy, whether it's a fusion biopsy or an in-bore biopsy that's done in the MRI. And then I will return to talk about a translational medicine space, which is the investigation and the emergence of the potential of focal therapy for prostate cancer. So most of us are aware that in 2020, 25% of all cancer diagnoses are prostate cancer. This tends to be a disease of older men, so about 2/3 of these are diagnosed in patients over the age of 65, with an average age of diagnosis of 66. 1 in 9 men will be diagnosed with prostate cancer during their lifetime, which in the United States translates into about 192,000 new cases of prostate cancer each year. Unfortunately, in 2020, still about 1 in 41 men will die from their prostate cancer, which translates into about 33,000 deaths annually. Very, very similar actually to breast cancer in women. So it turns out after lung cancer, prostate cancer is the second leading cause of cancer death in men. In terms of risk factors, probably the most important is age, because this is a disease that's rare under the age of 40 and increases decade over decade from about a 50% risk at age 50 to over 80% risk at age 80. Family history is important. So first degree relatives in particular, a father, brother, son with prostate cancer, this is very important in terms of the relative risk of clinically significant prostate cancer. Also, I know we have a very international audience here. So in addition to African Americans, also Caribbean men of African ancestry, for example, are at increased risk, about 1.8 times more likely to be diagnosed with and 2.5 times more likely not to survive their disease than their Caucasian counterparts. Turns out high geographic risk areas include North America, Northwestern Europe, Australia, and also the Caribbean islands, in particular Trinidad and Tobago, with one of the highest incidence rates in the world. Now, the opportunity for multi-parametric MRI as a disruptive technology exists because some of the traditional methods that Dr. Herz described have some problems that we are having to mitigate. One is that screening historically had been associated with overdiagnosis and overtreatment of clinically insignificant prostate cancer. And this is why screening PSA got a relatively bad grade a few years ago from the US Preventative Services Task Force of a D. Now that's improved since MRI's come along, but it was a problem. Also, we didn't have really very reliable screening tests available years ago, as Dr. Herz described. In addition, remember that an elevated serum PSA is prostate specific, but it's not prostate cancer specific, meaning it can be elevated due to BPH, so benign disease, prostatitis, but also due to prostate cancer. So how do we tell, which patients the elevation is due to cancer and which ones it's due to something else? Well, things like the PSA density can help us out there. The old clinical exam that most patients do not so much look forward to, the digital rectal exam, it turns out also is not very reliable for diagnosing clinically significant prostate cancer, misses about 2/3 of them. These things can combine to result in a delay in the diagnosis of clinically significant prostate cancer and also result in the overdiagnosis of clinically insignificant cancer. The systematic biopsy, the random 12-core transrectal ultrasound-guided biopsy that Dr. Herz described, unfortunately could miss up to about 30% of clinically significant prostate cancers. And when it did find prostate cancer, it would under Gleason score or undergrade the cancer in as much as 30 to 40% of the time. Also, both biopsies and unnecessary treatments can result in significant side effects, okay? The staging, which Dr. Helfand nicely reviewed, historically, we had understaging of exactly where the cancer has spread clinically in 15 to 25% of patients. So things like multi-parametric MRI and molecular imaging, such as Axumin and the PSMA type of molecular imaging, are really helping us out in this space. Also, some of you patients probably have been in active surveillance where you were thought to have low volume, low risk, grade group 1 disease, Gleason 3+3, that it turns out if you do a multi-parametric MRI in active surveillance patients, over 25% of them are found to have clinically significant prostate cancer that's a higher Gleason score that's been undetected that warrants them going on to definitive therapy rather than sitting in active surveillance until that clinically significant prostate cancer grows to a point where it becomes detected with traditional methods. And then Dr. Helfand has nicely covered the issue of biochemical recurrence and the problems that we've had in this space. So, the audience here is mostly, prostate cancer patients. And what do you care about? Well, we've done surveys, and we know that what you care about is detection of clinically significant cancer. You don't want to know about clinically insignificant cancer. In fact, you probably prefer not to be in active surveillance, and as many as 30% of patients in active surveillance end up in what we call inactive surveillance, where they just stop showing up for follow-up biopsies. So we don't want to find grade group 1 disease or Gleason 3+3 disease that's clinically insignificant. We want to find the clinically significant cancer, right? Quality of life is also important to you. We want to make sure that both the way that we diagnose your cancer and the way that we treat you preserves as best as possible functional outcomes. So erectile function, urinary incontinence, and also your mental health, right? Hormone therapy can really have some adverse effects, in particular in that space. You also want us to get an accurate Gleason score. That's a measure of the grade of the cancer. That's the most important biomarker still to date that determines your prognosis and how you're treated. You also don't want us to overtreat clinically insignificant cancer because of the side effects, right? Up to 50% of men can end up with erectile dysfunction, and 10 to 15% can still end up with urinary incontinence. So we don't want to be treating clinically insignificant cancer. You also care about the risks of treatment versus non-treatment. What do I mean by that? Well, we talked about the risks of treatment, but there are also great risks of non-treatment if you have clinically significant prostate cancer that's been missed. And then obviously, both at a societal level you care, but also in terms of co-payments and deductibles, you care about the cost of treatment. There are also some medical legal issues. Now, these are mostly for the United States participants in this webinar because of how litigious our society is. But if you look at the causes for medical malpractice, lawsuits for physicians who take care of patients that are diagnosed with prostate cancer, the failure to follow an elevated PSA or perform a PSA or report an elevated serum PSA, these are the most common causes for a medical malpractice encounter for the physician. But notice that failure to perform a multi-parametric MRI has now appeared in the literature and is going up in this list now that societal guidelines and clinical pathways have recently changed. Now, syzygy is a great Scrabble word. I'm going to use this ancient Chinese star map here to demonstrate what this is. It's an astronomy term that means that there's collinear alignment or lining up of 3 or more celestial bodies. And when this happens, astronomers get real excited, but the astrologers get even more excited. Here in the United States, a bunch of people will show up in Sedona, Arizona, looking for a spaceship to land or something along those lines. But I like to talk about the prostate syzygy. This is why I dropped everything I was doing 10 years ago and decided that now's the time to make sure that outpatient imaging centers embrace men's health imaging in the same way that 30 years ago, we put women's health imaging and breast cancer imaging centers in every single imaging center across the United States. Now, what caused me to do that was 3 things to line up. The emergence of a new type of MRI called the multi-parametric MRI to find prostate cancer that's clinically significant, the development of hardware and software solutions under MRI guidance that allow us to do either in-bore biopsies of the prostate gland or for our urology colleagues to fuse the MRI with ultrasound and do an in-office MRI ultrasound fusion biopsy. But the key is that the MRI is added to the intervention to add targeted biopsies to our toolbox. The third thing that's extremely important, especially in supporting the investigation of focal therapy and the emergence of focal therapy, is our improved understanding of the natural history of prostate cancer, especially the concept of the index lesion that a urologist really has put out there from, at the time, UCL in London, Hash Ahmed. The index lesion, basically this concept is that we know 80% of the time patients have multifocal prostate cancer, meaning in more than one spot in the prostate gland. But over 90% of the time, the largest, highest Gleason score focus of prostate cancer is the one that tends to metastasize, the one that determines prognosis, and the one that's most likely to determine the natural history of the disease in an individual patient. So if we can find this index lesion reliably and potentially treat it with focal therapy, we may be able to, treat prostate cancer with focal therapy, even though it's multifocal, in up to 80% of cases. Now, in 2020, the clinical pathway really has been disrupted. Screening serum PSA, if anything, has gotten better as a result of the addition of MRI, but we'll talk about multi-parametric MR and we'll talk about the role of targeted biopsy after we digress a little bit here to add a little bit of color to the screening serum PSA. One of the take-home messages of this webinar is that screening serum PSA, when used appropriately, is a great test, okay? This test helps for early detection, and it helps to reduce the mortality from prostate cancer by as much as 30%. Now, there's an old saying that a fool with a tool is still a fool. The problem wasn't that this isn't a great screening test that ended up with a grade of a D. The problem was we weren't using it appropriately. We have to use it in the right age range for screening, for example, so that we can avoid overdiagnosis and overtreatment of clinically insignificant cancer. So the elevated serum PSA, I mentioned, it's not specific for prostate cancer, that it can be elevated due to prostatitis or other benign disease like BPH. But when we combine it with other biomarkers that Dr. Helfand mentioned he's interested in, like PSA density and some of the genomic testing and things that's out there, suddenly the serum PSA test becomes much better as a screening examination. I mentioned the digital rectal exam misses 60 to 70% of clinically significant prostate cancers. It still can be very helpful, though, for clinical staging. Also, note that up to 15% of patients who have clinically significant prostate cancer have a normal PSA. So the serum PSA is not the whole story here. Now, the most common cutoff that's used for the serum PSA for screening at this point in time is about 3. The sensitivity, meaning if you got clinically significant prostate cancer, to find it with a cutoff of 3 is about 90%, and the specificity is about 25%. Now, it turns out detection of prostate cancer really is not occurring in the right age ranges yet. We're making good progress here. It turns out a baseline screening serum PSA between 40 and 45 is extremely useful. If that value is less than 0.8, there's very, very good data that you're extremely unlikely to develop clinically significant prostate cancer, even into your 80s. So get a baseline at a younger age, especially if you're at increased risk because of a first-degree family member, or if you're African-American or Caribbean African man. Notice that right now, only about 13% of patients between 40 and 54 are getting PSA testing, about 40% in 55 to 69, about 45% above 70. A grade of C was more recently awarded by the U.S. Preventative Services Task Force for screening serum PSA. In part, its improvement is because of adding the multi-parametric MRI to this clinical pathway. And here now we're getting it essentially above the age of 50, probably above the age of 75 for screening. It's not indicated. But as I said, a baseline between 40 and 45, there's growing data to suggest that this is very, very helpful. Also, why am I pushing this? It still turns out that screening PSA, when we use this tool appropriately, reduces the mortality of prostate cancer by at least 30%. Okay, with that, transitioning from screening, I'm going to hand off the baton to Ms. Greenwood, who is going to cover with you multi-parametric MRI and the emerging role of MR-targeted biopsy. Ms. Greenwood?
Thank you, Dr. Feller. Good evening, gentlemen, ladies, and thank you to us too for hosting us. So what is a multi-parametric MRI? Obviously, it's a clinically proven innovation. We are able to create highly detailed images of soft tissue anatomy. As highly detailed as it is, though, Dr. Feller talked about this multifocality of prostate cancer. If you've got prostate cancer peppered through your gland that's very, very tiny, sub-millimeter, MRI is not going to be the test that'll pick it up. But it's indolent disease typically, so we don't usually worry about it. That was to help answer a question I just got. It's very effective in the detection of clinically significant prostate cancer. It can facilitate a precise diagnosis when combined with PSA and PSA density. And PSA density is simply PSA divided by gland volume. It's estimated that MRI can increase the detection of clinically significant disease over other methods by about 50% and reduce the number of unnecessary biopsies and the morbidity associated with that by about 33%. So when we look at the different types of policy statements and guidelines that have come out over the years, European Association of Urology recommends MRI of the prostate in biopsy-naive men with elevated PSAs. Additionally, the American Urological Association in October of 2019 declared that MRI should be performed. It's supporting the use of MRI in men at risk of harboring prostate cancer who have never undergone a previous biopsy. So MRI prior to biopsy is the mantra these days. Looking at the National Comprehensive Cancer Network guidelines, this is a really interesting slide. So this is the 2020 early prostate cancer detection guideline. And look at this early detection evaluation column here. You've got PSA over 3 and suspicious digital rectal exam. Well, rather than giving you a mandate, you're told to go to another area. And then this other area talks about things like biomarkers and MRI targeting. So the references for this can be found in the supplement that us two will provide to you, but clearly biomarkers have a role combined with MRI to be able to risk stratify men and to understand what therapies might best suit them. Again, not to beat the dead horse, but emerging evidence suggests that use of multi-parametric MRI and or use of refined prostate biopsy techniques may help identify regions of cancer missed on prior prostate biopsy and be considered initially and certainly in selected cases after at least one negative prostate biopsy and high suspicion with continued rising PSA. So the American Urological Association, as I mentioned, they updated their guidelines. When we talk about the potential for MRI to be performed, it's indicated in over 1 million cases per year and about 0.5% of all men. The fastest growing CPT code, according to CMS, is MRI of the prostate, which is growing at about 28% per year. And this was even before the guideline change. When you compare it to what happened in mammography in the 1990s, as Dr. Feller referenced, that set a precedent for men's imaging and prostate MRI growth in this decade. So between 1987 and 2015, women over 40 who participated in mammography screenings increased from 15 million women to over 50 million women. In the same time frame, the mortality rate of breast cancer patients decreased by more than 40%. So 60 million men over 40 in the United States likely need screening, and in 2010, per 1,000, 5.2 men received a prostate MRI compared to 13.5 per 1,000 men in 2016. So at this rate, we expect more than 20 men per 1,000, about 1.2 million, to receive prostate MRI in the year 2020. So we talk about our little safety net. MRI is done treatment's been administered. What are we looking at next? There's other imaging, there's radionuclides, there's continued follow-up, PSA and imaging, MRI in particular. But the false negative rate of MRI is around 10 to 15%. PSA density could be used to increase the efficacy of PSA interpretation. So PSA density, as I mentioned before, is PSA divided by gland volume as established from the MRI or from an ultrasound exam. PSA density is greater than 0.15 nanogram per milliliter per cc can be a red flag. And we view it as an indicator that maybe systematic biopsy would be indicated if it hasn't been previously performed. And of course, we stick to MRI-based follow-up with MRI-targeted biopsy if we see MRI progression of a tumor on the MRI exam. MR targeting for Gleason score isn't its only attribute. Using MRI for targeting for tissue-based genomics can be very helpful. We've used all different types of genomic classifiers. The one that we have been doing research on is the Decipher test. And the goals of Decipher are to provide physicians with training so that they can do counseling for patients and explain what their prognosis looks like. But let's go to the next slide and I'll explain a little bit more about MRI and active surveillance. MRI can help determine best candidates for active surveillance. And this is critical because a lot of men are on active surveillance because they had a trust biopsy that showed 3+3. Dr. Feller mentioned that that's incorrect anywhere between 30 and 40% of the time. A lot of men on active surveillance have no business being on active surveillance. So about 26% of them are upgraded at MRI and moved over to definitive cancer treatment. We'll get into a little bit more detail about MR targeted biopsy in the next segment. So I coined the phrase poke and hope, which a lot of urologists don't like, and I apologize for that. But essentially, it's a random systematic approach, and they don't know where the tumor is. The problem is they can often completely miss the tumor. They could pick up something inconsequential that's not going to impact the patient while they're harboring something more aggressive elsewhere, or they could skim the edge of it while the aggressive component isn't even sampled. So again, 30 to 40% undergrading of Gleason score with trust biopsy. So in the long run, men only hit what they aim at. So there's a concept of the target within the target. Great paper by Jan Radke talking about genomic testing and the heterogeneity of tumors. There's different components within a tumor. And it's important that if you're going to get genomic testing or you're going to do Gleason scoring, you've got to go into the most aggressive looking area of the tumor. So as you know, there are a number of different MR targeted strategies. There's cognitive fusion, where a clinician will take an MRI, look at it and say, oh, the tumor's over here, then go do an ultrasound and aim at that region. It's cognitive. They're looking at it, they're thinking of it. Then there's MR ultrasound fusion, where the MRI is acquired and then it's fused to an ultrasound and they attempt to map the two onto each other to millimeter accuracy. And then there's MR guided in-bore biopsy, which, as Dr. Herz referenced, is inside the MR scanner, real time. We see the prostate, we see the tumor, we see the area of aggressiveness within the tumor, and that's what we aim at. So there are different routes. There's a transrectal route, transperineal route, transgluteal route. Again, each of them have their attributes. Our preference for transrectal is because we use broad spectrum antibiotics and we have a less than 1% infection rate. So we really see no need to go through the perineum or to do something transgluteal, unless of course the patient doesn't have a rectum and we're using CT guidance to go through the gluteal muscles under image guidance. So a key aspect of what we do is using software that helps us to aim with pinpoint precision at the thing that's the scariest. And this software is commercially available. It's not some fancy, super secret research thing. It's commercially available Anybody with an MRI scanner can get it. And the goal is to aim at the worst looking part of the tumor and take as few cores as possible. And so it's a team approach. There's multiple people involved. We've gotten it down to about a 25-minute procedure. And you can see the patient is positioned in the MR scanner. The urologist is putting a biopsy gun in there, taking 2 or 3 cores and calling it quits. So it's a very quick, very painless, easily tolerated procedure. So one interesting thing about MR guidance is we're able to actually take an image of the needle in the thrown position. And this actually goes into the pathology report. So literally in a court of law, it's indisputable where the sample came from. Other techniques can show where they think they went or where they hope they went, but this is actually where we ended up. So our published results on our MR-guided in-bore biopsies, out of 768 men, less than 1% excessive rectal bleeding, less than 1% hematuria, no acute retention, less than 1% urosepsis, and 0 30-day mortality, which is very different than trust biopsy, which harbors morbidity up to and including more than 0.4% risk of death. Uncomplicated UTI, same scenario, MR-guided biopsy, less than 1%, transrectal ultrasound-guided biopsy up to 3%. Over 6 years, 48 core biopsies in this patient with Gleason 4+4 prostate cancer. If you look at the image, you could see the area of the biopsy is only as good as the needle throw. So those little graphics showing the depth of the throw of the needle are the problem, because it's a 2-centimeter depth, and then way far anterior, way toward the front, is this aggressive 4+4 cancer. So this guy could have had biopsies year over year over year, which he did over 6 years. Biopsy after biopsy came up negative. Meanwhile, he's harboring 4+4. And the problem is, just like little Kobe Bryant trying to go after Yao Ming, no matter how high he jumps, he's never going to get it. So no matter how many times they throw the needle, they're going to miss the far anterior cancers. And when we talk about 12-core random biopsy compared to MR targeting, there's something that we call core quality. When that core comes out, how long is it? How much of it possesses cancer? So when we look at low-risk cancer, MR targeting is a little bit better. But then as we start looking at moderate risk and high-risk cancers, look at how much better MRI targeting is at filling that chamber with actual cancer. So this is definitely an argument for in-bore MR-guided biopsy as core quality. But then culture eats strategy. And what do I mean by that? Upton St. Clair said, you can't incentivize a man to understand that for which he's paid to not understand. So we have a situation where radiology is doing one thing, urology is doing something else, and we insert government and insurance companies and administration and all these conflicted entities that prevent radiology and urology from holding hands and singing Kumbaya. And you can almost make the analogy, it's like, you know, the United Nations having 193 countries and Britain divided and conquered 171 of them. So what we have to do as professionals is take a team approach to this disease and bring in specialties and hold hands and sing Kumbaya. And what ended up changing the course of history in terms of prostate cancer management is the addition of multi-parametric MRI. And what's important about it? We've got now multiple platforms that we can integrate MRI with fusion. These brands are not, you know, special to me in any which way. They exist. There are many on the market. They're all commercially available. And when we look at MR ultrasound fusion compared with ultrasound guided biopsy, you've got an increase in detection of Gleason score greater than equal to 4+3. MR targeting biopsy diagnosed 30% more high-risk cancers than standard trust. An MR-targeted biopsy diagnosed 17% fewer low-risk cancers than standard trust, which, to Dr. Feller's point, we want to pick up the high-risk stuff and ignore the low-risk stuff. That's how we stay away from the morbidity associated with overdetection and overdiagnosis. So, summary, advantages of the MRI-based clinical pathway: 30% fewer patients undergoing prostate biopsy, fewer cores per patient, reduced complications, improved quality of cores, both for histology and genomics, detection of clinically significant cancer, and detection of less clinically insignificant cancer, improved Gleason scoring and staging, and recommendation or not for active surveillance, improved clinical staging, and improved cost effectiveness. There's your case for MRI and MRI targeted biopsy. And with that, I will pitch it back to Dr. Feller.
Thank you, Ms. Greenwood. As Dr. Helfand mentioned earlier, there's this real push, not just in the prostate cancer realm and space, but also with medicine in general, to really pursue personalized healthcare. We treat advanced imaging as if it's a biomarker because it meets the strictest definitions of a biomarker. But we add to that other biomarkers. So in our prostate cancer detection program, in addition to the multi-parametric MRI, if the serum PSA is elevated, as was mentioned, we look at the PSA density, but we get tissue-based genomics on all of our image-guided biopsies. We also get a blood draw on the patients that have clinically significant prostate cancer and look for circulating tumor cells, circulating tumor DNA. We get a urine sample looking for exosomes. And this data can all be brought together in a way that helps to risk stratify men better for what specific therapy that individual man should undergo. So with that in mind, I'd like to transition over to the concept of focal therapy. Everything we've talked about so far is part of societal guidelines. There are 4 level 1 studies at this point that show the advantages of the MRI-based pathway compared to the systematic transrectal ultrasound-guided biopsy, and that's caused the guidelines at societal levels to change. So that's all, part of the standard of care, and really just needs to be rolled out in a quality way worldwide. Focal therapy is in the translational medicine space. So we choose laser as the energy source, and we've been studying this for about 10 years now. We have 10 years of follow-up in our patient cohort. And the reason we chose laser is that it's safe and it's precise. And the reason it's safe and precise is that the transition zone with laser as an energy source is only 1 millimeter. So the difference in distance between tissue that we've destroyed and tissue that's completely viable is only 1 millimeter. And that distance is a lot greater with other energy sources like cryotherapy and HIFU. In addition, we've developed this in a way that we can perform it in an outpatient setting. So we have no general anesthesia, no anesthesiologist involved. We do a nerve block, we use a topical anesthetic for the rectal wall, and then we use conscious sedation through an IV with a nurse monitoring the patient and an interventional radiologist performing the therapy. We also have this high degree of safety because we can use MRI thermometry. This is a way to measure temperature inside the human body real time without sticking a thermometer in you or putting a thermocouple inside of you. We can just use an MRI pulse sequence using radio waves and magnetism to measure the temperature in your body real time to be able to treat things like prostate cancer. We can monitor the temperature within the treatment area, but also we can put safety cursors on critical structures like the external urethral sphincter, which keeps you from having to wear a diaper the rest of your life due to urinary incontinence. We can put it over near the nerves that control erectile function, and we can also put them on the rectal wall. And these cursors, even if the physician doesn't see things heating up, the laser system will shut itself off if these important structures start to heat up during the treatment. So pretty much annually, we've been presenting the results of a phase 2 trial. So this means that safety has already been proven and feasibility with a phase 1 trial, which we did years ago. But a phase 2 trial is actually looking at efficacy, which means, well, how good does this perform? And when we say how good does it perform, we look at both its oncology control, so how well does it control the cancer, but then we also look at functional outcomes. How well does it prevent erectile dysfunction? How well does it prevent incontinence? We presented it again this year. This was the 10-year interim results at the AUA meeting this year, and the abstract was published in the supplemental Journal of Urology in May. So an overview of the phase 2 clinical trial is that we're on our way to 200 patients. We've done 181. 85% of our patients are treatment naive, meaning they've had no previous treatment for their clinically significant prostate cancer. 15% of our patients are salvage patients. These are patients that have failed other types of primary therapy. That can be a radical prostatectomy. It can be any form of radiation therapy. It can be other forms of focal therapy. It can even be hormonal therapy and chemotherapy. But 15% of our patients fall into that category. We do this, as I mentioned, as part of an IRB approved clinical trial currently, but we're transitioning over to a commercial offering of this in the first quarter of 2021, so here in January. But we do this outpatient, and this is true focal therapy. Our goal is to use the laser to eliminate the MRI abnormality associated with the prostate cancer with one caveat. We try to put a 1 centimeter margin around the MRI abnormality because we know the MRI underestimates the size of the cancer by up to 30% of the volume and up to 7 millimeters in one direction. So we put a centimeter margin around the treatment. We do a 6-month biopsy of the treatment site in all patients and an MRI at 6 months. We get patient-recorded outcome measures like the International Prostate Symptom Score, Sexual Health Inventory for Men, and also a mental health questionnaire, as well as following the PSA density, and then the patients also get yearly multi-parametric MRIs. So we actually have biopsy proof of what we're doing at the treatment site in all of these patients, and then 10 years of MRI-based active surveillance. The age range of our patients is in the mid-40s into about 92, actually, interestingly enough. If you look at the Gleason score breakdown in the treatment-naive patients, 60% of the patients are Gleason 3+4 or grade group 2. 27% are grade group 1, 3+3, but we only accept patients that are MRI visible Gleason 3+3s that are large volume, meaning over definition mostly in the literature is a cancer that's more than 1.3 to 1.5 centimeters in diameter. And then our 4+3s in the treatment naive, so grade group 3 is about 16% of our patients. Obviously, our salvage patients have Gleason scores of all different types. If you look at the PSA results, in our treatment naive patients, at 12 months, the PSA comes down about 37%. It does not go to 0 because this is focal therapy. So the rest of the gland that's still preserved that normally makes PSA continues to do that. In our salvage patients, not surprisingly, there's a greater decrease in the average or mean PSA. It's more like about 60%. The Sexual Health Inventory for Men, which is a patient-recorded outcome measure for erectile function, we have no statistically significant difference 1 year after laser focal therapy, whether the patient's treatment naive or salvage. If we look at the International Prostate Symptom Score, so this is kind of a measure of urinary symptoms, incontinence, difficulty voiding. Also, no statistically significant difference at 1 year in men that have had MR-guided laser focal therapy in either treatment-naive patients or in those that have previously been treated. If you look at our mental health patient-recorded outcome measure, the PHQ-9, which is a measure of mental well-being, again, no statistically significant difference at 12 months in our patients in this 10 years of follow-up. Now, if we look at the biopsy results at 10 years in our patient population, we have 2 different types of biopsies. One is that we biopsy the treatment site in all patients. And over the course of 10 years, 21% of our patients at 10 years have clinically significant prostate cancer at the treatment site. In addition, separate from the treatment site called out-of-field recurrence, clinically significant cancer 4% in our cohort of patients over 10 years. If we look at metastasis-free survival, so the percentage of men that do not develop metastatic disease, at 10 years, it's 99%. We only had one patient develop bone metastasis or lymph node metastasis. At 10 years, none of our patients died of prostate cancer in this trial. So their cancer-specific survival at 10 years is 100%. So the oncology control, at least at 10 years, is comparable to whole gland therapy. If you summarize all of our results at 10 years of follow-up using laser focal therapy, in 95% of our patients, they came back and actually got their biopsy of their treatment site. So the compliance rate was very high. Also, all of our men are showing up for their MRI-based active surveillance. We tell them that this is a new paradigm for treating their prostate cancer, that many of these patients may die with their prostate cancer, but not from it, and that if they need repeat laser focal therapy, we can do that. It's kind of like giving them a haircut. And so far at 10 years, their recurrence rate at the treatment site, 21%, outside the treatment site, 4%, and this is clinically significant prostate cancer. Also, no statistically significant erectile dysfunction or urinary incontinence 1 year out. Only 6% of our patients have had to be moved over to whole gland therapy at 10 years. So 94% were able to avoid a radical prostatectomy or radiation therapy. Our metastasis-free survival, 99%. Prostate cancer-specific survival, 100%. The very first treatment, meaning we're one and done, we're able to accomplish in 79% of patients. In the 21% plus 4% that get either an in-field or out-of-field recurrence of their cancer, 90% of those patients have elected to have a repeat laser focal therapy, and they're doing very well. The other key thing with laser focal therapy is we don't burn any bridges with regard to other treatment options. If a patient does have to be moved over to whole gland therapy, we can confidently do that. And we've gotten feedback from our urologic surgeons and from the rad-onc people that it has not significantly compromised their ability to do whole gland therapy following laser focal therapy. And the good news is that our numbers compare very favorably to recurrence rates for radical prostatectomy and radiation therapy for intermediate risk prostate cancer. So Gleason 7 disease, 3+4 or 4+3 that's organ confined. Biochemical recurrence rates are 20% at 5 years, 30% at 10 years, and as you heard earlier, as much as 50% at 20 years. So our oncologic control is very comparable, but our functional outcomes are a lot better. So again, we chose laser rather than cryo or rather than HIFU or other energy sources because of how safe and precise it is, because this transition zone is so narrow. It's only 1 millimeter compared to the 5 to 10 millimeters from these other energy sources. This real-time thermometry and these safety cursors allow us really to sculpt the therapy. We can carefully avoid important structures like the external urethral sphincter. So this type of approach with focal therapy and laser is particularly amenable to treating apex cancers. These are cancers that are real low in the prostate gland down towards your feet, where this external urethral sphincter is located that we need to protect. And we use a urethral cooling catheter and something called continuous bladder irrigation to cool the apex and that little muscle while we're treating these cancers that are down there. It also works very, very well in large volume prostate cancers that are difficult to reach otherwise, that we can reach under MRI guidance. So what are the take-home messages from the three speakers, Dr. Herz, myself, and Ms. Greenwood in this section? First of all, MRI, especially multi-parametric MRI, is a disruptive technology. What has that disruption resulted in? Well, it's made screening serum PSA a much better test. Get your screening serum PSA, a baseline between 40 and 45, and then obviously yearly above the age of 50 to at least 75. We know this reduces your mortality by prostate cancer by at least 30%. That number may be even higher. If your PSA is elevated, unlike years past where you would go to get a systematic biopsy or random biopsy, the new guideline in the European Union, here in the United States and around the world is following it, is that you get a multi-parametric MRI before any type of biopsy. If that MRI is abnormal, which is in about 60% to 70% of cases, your biopsy should include a targeted biopsy. That may be an in-bore biopsy done by radiologist or a fusion biopsy done by urologist. I don't care which way it gets done. It's the MRI that's the game changer. If you have clinically significant prostate cancer, get a multidisciplinary consult. See your urologist, see your radiation oncologist, your medical oncologist, but also now more and more also seeing an interventional radiologist is emerging as an opportunity where MRI-guided laser focal therapy is emerging as a treatment option. And with that, I'd like to acknowledge our entire kind of research and development team and also our clinical team at the Halo Diagnostics centers here in Indian Wells, California, that really have been passionate, again, about trying to put men's health imaging on the map the same way we did with women's health imaging 25 years ago. And thank you so much for your attention.
So thank you guys so much. Such a wild and exciting time in the prostate cancer world. So we know it's getting a little bit late, but our Halo DX team is willing to stick around, and we've got several questions. We want to try to get through some of these questions. So we welcome everyone to just stay if you like. We've got some questions we're going to go through, and we're going to put the team back on all together, and then we'll start asking some of those questions. AJ, am I ready? Okay, it's Dr. Feller, you've got Dr. Herz with you, right? Because that's first questions for him.
Sure do.
Okay, excellent. So Dr. Herz, our first question. I had aggressive prostate cancer in 2009 due to Agent Orange. The VA gave me 25 days of EBRT followed by brachytherapy, 41 seeds. In 2014, his PSA started to slowly rise with each new test. Recently, PSA more than doubled in less than 9 months. Due to the seed reflection echoes, conventional imaging is whited out and tumors cannot be seen. Am I stuck waiting for the cancer to metastasize so that new tumors outside the prostate can be imaged and treated? However, if the original source of the deadly cancer cells is not destroyed, it will continue to spread its evil cells throughout my body. Salvage therapy and ADT are not options for me. I need imaging that can see past the seed echoes to discover the location of the tumors.
Well, it's a long question, but it's a really good question, and it's right on point for what we've discussed. First, it's not unusual. This is not an unusual story for recurrence of prostate cancer. And in the past, as I indicated previously, most of the patients that we found with prostate cancer before PSA testing were on their way to the grave because we found them too late and we didn't have good treatment when it already had spread. But today, that really is not the case. And what we've done really is with these treatment modalities like PSA testing, MRI imaging, MRI-guided biopsies to find early prostate cancer, is we've converted a previously fatal disease into a chronic disease, much like arthritis or high blood pressure, where you take a pill and off you go, you know. And so it's the same kind of a situation with prostate cancer. When you have recurrence, we have really good treatment modalities that are now available to be able to treat those patients and diagnose them properly for the best treatment. So directly to answer this question, as far as imaging is concerned, to see what we're doing, yes, MRI imaging can find the cancer in this patient in spite of the fact that he had brachytherapy. When he's talking about other treatment modalities or other imaging modalities, he's talking about things like ultrasound, for example. But MRI imaging can find his prostate cancer lesion in the prostate and target it, biopsy it, so we can confirm what the Gleason's grade is. And with focal therapy, as Dr. Feller mentioned, we can treat that cancer locally very, very well. And we have done so in several patients with similar stories with brachytherapy, and we've done very well with those patients. So no problem. And of course, patients like this will need imaging studies to see if they have any spread of the disease. In other words, we have to stage them. So imaging like the Axumin imaging that Helfand mentioned, PSMA imaging as well, are imaging modalities that we didn't have before and that are available today under these circumstances. Great question.
Thank you, Dr. Herz. Okay, next question is for Dr. Feller. You guys going to switch?
We're going to switch.
There you go.
Okay. Dr. Feller, I'm coming up on 7 years since my initial diagnosis and treatment. I was diagnosed as a 3.1 inoperable because cancer reached the edge of the membrane of the prostate. I received radiation and hormone treatment, and my PSA is currently 0.1. I am wondering if a scan can reveal if the cancer is still within the prostate and if I am a candidate for further treatment, such as cryotherapy, before it's too late.
Yeah, so a great question that kind of focuses on imaging in the situation of biochemical recurrence, response to therapy, and also evaluation of kind of, next steps. So in this situation, we advocate for doing 2 tests. One is the multi-parametric MRI that gives us a clearer look at whether or not there's local recurrence. And you might say, well, but the PSA is only 0.1. Well, we have to remember, first of all, that 15% of prostate cancers that are clinically significant, the PSA is in a normal range. And also as the prostate cancer mutates and changes in response to therapy, it can get poorly differentiated enough or aggressive enough that it actually doesn't make PSA. And some of the most aggressive prostate cancers, you can think everything's okay because the PSA is low, but in fact, there's aggressive cancer there that just doesn't make the PSA. So we advocate for doing a multi-parametric MRI to look for local recurrence and to look at local staging. And then as Dr. Helfand reviewed, doing molecular imaging for the distant metastatic disease. So the lymph node involvement, the possibility of bony involvement. Right now with Axumin, but there's some other horses in this horse race, the PSMA PET CT that is coming online and is, phase 3 trials right now, and probably is going to have some increased availability. So the answer is a combination of a multi-parametric MRI and molecular imaging, most commonly Axumin. And then you are a candidate actually for salvage therapy. There's been work done with HIFU, with cryo. In our own experience, laser has been particularly good in the salvage patients, again, because of this very narrow transition zone, how safe and precise it is. And in particular, for patients had prior radiation therapy, where the rectal wall is really at risk from other forms of focal therapy.
Great. We've got another question for Dr. Feller, so I'll ask you so you don't have to change chairs.
Okay.
So next question, what is the latest knowledge of gallium, and does it accumulate in your brain and have long-term side effects?
So I'm going to kind of read between the lines here a little bit. First of all, the answer to this question is that gallium does not accumulate in the brain at all. But I think they meant to ask a different question that's much more controversial, and gallium is a nuclear medicine agent that we use, for example, with PSMA PET CT. I think what they wanted to get at is gadolinium, which is kind of a similar sounding rare earth element that's the basis for contrast agents for multi-parametric MRI. There is some evidence that some gadolinium contrast agents are retained in the central nervous system, so in the brain and in the spine. That is true, and it's caused a lot of practices. For example, all of our Halo Diagnostics sites, we've moved over to a cyclical gadolinium-based contrast agent, which has less of a chance of accumulating in the brain or in the spinal cord. Having said that, there is absolutely no proof that that little bit of accumulation, which is very minor, actually causes any clinical symptoms or causes any disease state. So I think we need to be real careful here, because gadolinium is actually very, very helpful, even in prostate cancer patients. So multi-parametric MRI, where we give contrast, this gadolinium-based contrast agent, is the standard of care. That's what is part of PIRADS version 2 and the standard of care. Biparametric MRI is investigational. It's being studied, but it is not the standard of care. It does not include the intravenous contrast, and it's being looked at for its potential to be used as a screening exam. That ADMETech has kind of pioneered the phrase manogram. That's kind of like the mammogram, but that's still investigational.
Thank you. So I've got a couple more questions. The next question is for Dr. Herz, and then I've got one that's kind of for the team. So however you guys want to handle that.
Okay. Take my mask off here. Okay.
Yeah, I got to be careful.
Yeah.
Okay, Dr. Herz, this person would like to know if someone is 5 years cancer-free, should he still be concerned about recurrence?
And the short answer is yes, he should be. But there's a little longer answer to that. So the longer you are out of diagnosis and surveillance of your cancer, the better you're going to do. So 5 years is great, but you can't assume that just because a 5-year period has occurred where you've been cancer-free, or we haven't been able to detect the cancer, that means that we don't need to continue surveillance, particularly for prostate cancer, because we know prostate cancer tends to be a slower growing, more indolent kind of cancer. And we look at 10 to 20 year survivals for prostate cancer, as opposed to other kinds of cancers that may be more active, like lung cancer or colon cancer. So particularly for prostate cancer, you cannot assume that 5-year survival means you're cancer-free. You really still need to watch PSA tests, and occasionally, depending on what the PSA test is showing, you may need an MRI imaging if PSA testing is rising, for example.
Great, thank you. And we've got one more question that we have time for. The question is, and then you two can decide how we want to answer. It's a more general question. Will MRI replace biopsies for diagnosis and grading of prostate cancer?
Well, is Ms. Greenwood on there? She kind of covered the targeted biopsy part.
You know what, we lost Bernadette. We had a technical glitch there.
Okay. No, then I'm happy to go ahead and take that.
Okay.
For many reasons, that's not on the short-term roadmap right now, that the MRI can replace the biopsy. You heard already that the MRI misses up to 10 to 15% of clinically significant prostate cancers, and we have to use the PSA density and some other testing as a safety net. In addition, there are false positives. That means where I look on an MRI and I think, oh, that's an obvious prostate cancer, but the biopsy comes back and it's inflammation. For example, patients who are getting their bladder cancer treated with BCG, they can get granulomatous prostatitis that looks exactly like prostate cancer on an MRI. So we still need the biopsy. Fortunately now it's image guided, so it's a targeted biopsy that we obtain for the histology, which gives us the Gleason score. But the other reason we need the biopsy is now most cutting edge sites are also getting tissue-based genomics. So we're getting the genomic information about the cancer. How bad of an actor is it from kind of a genetic expression standpoint? And we can't get that information from just looking at an MRI. So, far down the road when we get the Star Trek tricorder that can find cancer, stage it, grade it, do all that sort of stuff, we may get there eventually, but that's not going to happen, I think, during my career here in the short term. We're still going to need the imaging for detection, the image-guided biopsy, not just to verify what it is, but to get histology, get genomics, get this other information that's very important for personalized healthcare.
Thank you so much. So we are running out of time. So do you want to sum anything up for us, Dr. Feller, as a last statement before we give our thank yous and say goodnight?
Just that it's a hopeful statement. As Dr. Herz, covered before, I don't think there could be a better time actually for a man to have to deal with, finding prostate cancer early, detecting it, figure out which ones are the bad behaviors, then figuring out how to treat it based on very personal information that we can get now with other biomarkers, and therapies that are quickly evolving, therapies that have similar cancer control to some of our older ones, but also don't cause some of the side effects, but also therapies that are in the pipeline that even if it seems like you're in a hopeless situation right now, if you just hold on and you use the salvage therapies and the other tools that are out there, there are some amazing things in the pipeline. Immunotherapy, for example, oncolytic virus therapy that can be real game changers down the road. And even get us to a point where we're talking about cures for advanced metastatic disease, like what's happening with the radioligands, the lutetium-177, PSMA therapy. So keep the hope up. There's lots of great work going on out there.
Awesome. Thank you so much. So we're going to wind down now, and we're just going to say goodnight. So I just want to thank all of you for joining us tonight. Thanks for hanging out. We had a lot of people on the call tonight. We want to be sure to give special thanks to our sponsors, Janssen, Blue Earth Diagnostics, and HaloDX. Thank you so much again to our dynamic panel of presenters. I want to thank our US2 board, our amazing staff, James, Tim, and Tracy, for all the work that goes on behind the scenes to make these webinars possible. I hope everyone has a peaceful Thanksgiving holiday full of love and laughter, even though we might have to be virtual this year. So please stay safe, everyone. Stay safe and sound. Take care of yourselves. And good night. Thank you so much.